Good morning, dear colleagues. Today we are going to look at some recent data on the association between the use of proton pump inhibitors and development of kidney disease. Specifically, we will discuss a study that shows whether proton pump inhibitors can cause chronic kidney disease without developing an acute kidney injury episode. So I think we all would easily agree that proton pump inhibitors are one of the most frequently used classes of drugs in medical practice. Data from United States shows that almost 8% of US population had used prescription PPIs in last 30 days. However, please remember that proton pump inhibitors are available over the counter even in the United States and definitely in India. Therefore, this figure is likely to be an underestimate. We know that proton pump inhibitors have been associated with development of nutritional deficiencies, rebound acid hypersecretion, development of gastric carcinoid, cardiovascular disease when people receive clopidogrel and PPIs together, bone fractures, enteric infections, and pneumonias. Now, from our nephrologist point of view, a number of renal adverse effects of PPIs are known. The most well-known of these is acute kidney injury, in particular acute interstitial nephritis. But more recently, we have also become aware of new cases of chronic kidney disease developing in people who use proton pump inhibitors, and the fact that proton pump inhibitors might lead to accelerated progression of chronic kidney disease in those with pre-existing disease, and indeed also lead to development of end-stage kidney failure. So let's look at some accumulated data so far, and this is a meta-analysis which appeared earlier this year, which looks at the association of PPI use and the risk of development of acute kidney injury. And as you can easily see here, that the diamond falls to the right of line, which shows that PPI use increases the risk of development of acute kidney injury and chronic kidney disease as well. The number of studies here are small, and the number of total number of subjects is different from the previous graph that you saw, but clearly the risk of developing chronic kidney disease is also increased with the use of proton pump inhibitors. This is a separate meta-analysis. Now, we do know that the relationship between acute kidney injury and chronic kidney disease is bidirectional. There are a number of risk factors which play either in a common way or separately in development of both acute kidney injury and chronic kidney disease. Both of them are also influenced by a number of disease modifiers which are shown in the rectangle in the middle, and both of them can together lead to a number of adverse outcomes. So there can be two possible pathways for development of chronic kidney disease in a person who also has acute kidney injury. It could be either a linear pathway, that there are risk factors which lead to acute kidney injury, which leads to chronic kidney disease, which can increase the risk of mortality. But then there could be other pathways also. So risk factors could either directly lead to chronic kidney disease, or risk factors could produce acute kidney injury, and in the person does not fully recover from it and goes on to develop chronic kidney disease, and chronic kidney disease certainly increases the mortality risk. On the other hand, acute kidney injury can directly lead to death without development of chronic kidney disease, and risk factors can cause death without either intervening acute kidney injury or chronic kidney disease. We do know that acute kidney injury can take a number of trajectories. It can either recover completely or very close to complete recovery. It recovers, then there is a second episode of acute kidney injury, and then there is a further recovery which may not be complete. There can be rather incomplete recovery, or there can be close to no recovery. However, there is also a situation where you have either subacute acute kidney injury and or normal kidney function, and there are insults which lead to slowly progressive declining kidney function, which is known as chronic kidney disease classically, right? So This is the trajectory which was examined in this particular paper, which we'll discuss in slightly greater detail. So what did these people do? They examined the United States Department of Veteran Affairs administrative database, and in that database they looked at individuals who had used acid suppressive therapy, which could be either proton pump inhibitors or H2 blockers over a certain 3-year period of time. And they took care to exclude everyone who had received any prescription over the last several years. So these were new users of acid suppressive therapy. And these people all had normal kidney function as shown by eGFR greater than 60 mils per minute in the 90 days before starting the acid suppressive therapy. The subjects were required to have at least one eGFR measurement between the date of starting acid suppressive therapy and either one of the following events, either development of acute kidney injury, ESRD, death, or a 5-year follow-up, over a 5-year follow-up period. Participants who were prescribed H2 blockers at T0 and then subsequently got PPIs were excluded because they wanted to study individuals who were on one form of therapy in a pure way. And they also excluded subjects who had missing data or covariates. So what were the outcomes they examined? They examined incident eGFR less than 60 mils per minute, just one value. And then they examined incident CKD, which as per definition requires 2 eGFRs less than 60 mils per minute, at least 3 months apart. They also looked at a couple of other eGFR decrease values, which are now accepted by FDA as important surrogate endpoints, which was greater than 30% decrease and greater than 50% decrease in eGFR. They defined AKI as per KDIGO criteria. The various covariates that they examined are listed in the second bullet point below the horizontal line. In addition to that, they also corrected for a bunch of baseline parameters. This was the analytical approach they took. So T0 is the time when the acid suppressive therapy is started, and 5-year end of follow-up is, so this time period is shown here as analysis C. It is possible that a few individuals in this follow-up period would experience a chronic renal event, and so they did analysis between T0 to the time of chronic renal event, which is A or B. So in B, they exclude participants with AKI between T0 and chronic renal event, which means they exclude all individuals who developed acute kidney injury between these 2 time points. In analysis C, which is the total follow-up period, they excluded participants who developed AKI anytime during this entire period. In analysis B, we talked about analysis B. In analysis A, they censored at the time of development of AKI between these 2 time points. So censoring means that they continue to include the participant, but they use the data only till the time AKI occurred. All right, but they also looked at analysis D, in which they excluded participants who had AKI before they started acid suppressive therapy to exclude its effect on chronic development of chronic kidney disease subsequently. So they had close to 144,000 new users, and as expected, majority were on PPIs, and just about 10 to 12% of all individuals had received H2 blockers. An overwhelming majority did not develop an acute kidney injury during the entire time, and the baseline characteristics of these people were similar, who used either H2 blocker or PPI, except that PPI users are more likely to have a few chronic conditions, as is shown here. So this is the results of the analysis. So as you can see that PPI users, I think right off the top of the bat, I think it can be clearly shown that PPI users showed increased risk of development of either incident eGFR less than 60, incident chronic kidney disease, which means 2 GFR values at least 90 days apart, eGFR decrease greater than 30%, ESRD or greater than 50% decrease in eGFR. So this was consistent across all analyses. So PPI users compared to H2 blocker users are at increased risk of development of all these endpoints. So now let's look at the results of these various types of analysis that we showed. So this is the survival model of association between PPI use and chronic renal outcomes, where the referent group is H2 blocker, in which cohort participants were censored at the time of AKI occurrence. And you can see that either the univariate or multivariate hazard ratio continues to be significant for all the endpoints. Now, in this is a multivariate logistic regression model, and there, they have included all subjects where the last EGFR before the first occurrence of AKI, ESRD, or end of follow-up was used to define outcomes. And once again, you see that all, whether according to univariate odds ratio or multivariate odds ratio, all the endpoints are significant. And the multivariate model was controlled for a number of parameters, which are too many to read, but you can see that they have corrected for a number of things. So this is the next type of analysis, in which the cohort participants included those with no AKI before the onset of chronic renal outcome. So they excluded from the cohort entry all participants who had AKI between the time of cohort entry and before development of chronic renal outcome. So these are all people who developed AKI before developing chronic kidney injury excluded. And you see everything again significant. Now, this analysis has cohort participants who had no AKI between the time of cohort entry and the end of follow-up. So even those who developed AKI before development of chronic renal event or AKI after the development of chronic renal event, all of them were excluded. And again, same parameter. So this is the next analysis in which the cohort participants with no history of AKI, no AKI before cohort entry, which is before the time of starting acute the acid suppressive therapy, and also in which cohort participants were censored at the time of AKI occurrence. So same type of results. So we don't need to go into each and every figure, but I think the direction is very clear. So then what they did is they performed, since a significant number of individuals had acute kidney injury before they developed chronic kidney disease, they performed analysis which are called mediation analysis, and they try to estimate what is the proportion of individuals in whom the development of chronic kidney disease is explained by an intermediate episode of acute kidney injury, and what is the proportion in which acute kidney injury does not explain the development of chronic kidney disease, which means the chronic kidney disease developed irrespective of development of acute kidney injury. So this is how they can show it. And A, B, C, D are again these 4 different outcome parameters. So concentrate on the pathway B, which is the direct development of the outcome, which is incident EGFR less than 60, incident CKD, incident 30% decrease in EGFR, greater than 50% decrease, or ESRD. And you can see that in more than half of the subjects, this is the pathway which explains the development of chronic renal disease. In less than half, about between 44 to 46%, an intermediate episode of acute kidney injury explains the development of chronic kidney disease. Now, then they went ahead to look at the cumulative duration of PPI exposure and the risk of chronic renal outcomes. This is really important because often we start our patients on PPIs and if we forget to stop them. So patients keep on taking PPIs, and patients sort of become used to the idea that every time they go to a doctor and complain about gas or burning, the doctor prescribes a PPI, and that is what they should do. And so they start going to the chemist shop and asking for a PPI themselves. So does a prolonged use of PPI continue to increase the risk of development of chronic kidney disease, or is there a threshold beyond which there is no further increase in risk of chronic renal outcome? And so this is really alarming, which shows that there is a linear relationship between the development of adverse renal outcomes and the duration of PPI use, and there is no plateau reached at any point. So the longer the patient continues to use PPI, the more is his or her risk of developing adverse renal outcome. They did a number of additional sensitivity analysis to look at seeing if the analysis were done in some other way, will the results change? So what they did is that they used ICD-9 criteria in place of the KDIGO definition of acute kidney injury. They also looked at incident H2 blocker users who switched to PPIs, and they model it in a time-dependent manner. So this is again a statistical tool. Then other statistical tools which were used were instrument variable approach, which accounted for a lack of random assignment of PPI and H2 blockers, because you can say that people who are actually more in need of some acid suppressive therapy are more likely to receive PPIs, and so they are more likely at risk of developing chronic kidney disease. So the prescription is not random. So that was also corrected for in this instrument variable approach. And finally, they performed a high dimensional propensity score adjusted models. But the point is that all of them were consistent with the primary analysis results, and so nothing changed really. So final thoughts. Monitoring for acute kidney injury or acute interstitial nephritis is not sufficient to guard against development of chronic kidney disease in users of proton pump inhibitor therapy. And I think one can always say that subclinical or undetected acute kidney injury might have been missed in these subjects, which is always possible, but clearly there is a cumulative effect. So one can't say that it was all due to missed acute kidney injury. Now, what are the biological mechanisms of development of chronic kidney injury, which of course require study and are unclear at this point? And a number of hypotheses have been proposed, which include altered gut microbial composition and metabolism. It is well known that the suppression of pH, in the acidic pH in the stomach, does lead to proliferation of microbial flora in the stomach, but it could change the microbial flora in the rest of the gut as well. Experimental data does show that PPIs limit the renal tubular regenerative capacity, and that they cause sustained activation of heme oxygenase. Now, heme oxygenase paradoxically is an enzyme which is supposed to be protective against kidney injury, but it is thought that this protective effect is either abrogated or even reversed by PPIs. A number of other things have been also shown in the intracellular functions, such as impaired lysosomal acidification and proteostasis, which leads to increased oxidative stress, telomere shortening, which leads to increased aging or senescence. And there could be, of course, other mechanisms which need to be studied. Before we go, I think it is important for us to be careful our prescribing habits for proton pump inhibitors. And I would like to draw your attention to this, this guideline, which has appeared recently and was recommended by the College of Family Physicians of Canada. And they describe how you can de-prescribe proton pump inhibitors. So people who have been started on proton pump inhibitor therapy, what does the evidence suggest on how you can actually limit their use? And you can see the web link which has this particular guideline, which is available free, so you can go ahead and download it. So I think this is a cautionary tale which tells us that we need to be careful in prescribing drugs. Keep in mind what might happen in the long run in a very insidious manner. Specifically, I would draw your attention to renal transplant recipients who quite often complain of gastric symptoms or reflux, especially if they are on mycophenolate mofetil or mycophenolate sodium. And an instinctive reaction for many nephrologists and transplant physicians is to prescribe PPI therapy. So I think we need to be careful while doing it. Thank you very much for your attention.